Good evening, everyone. When I stand in this place, I'm a very proud MLA, and never to be referred to as a minister, just Susan if I ever want to get reelected. So from Susan, genuine thanks for all of you being here tonight. We want to have the time this evening for you, so I will speak very briefly. I do want to begin by acknowledging that we are in Mi'kma'ki, the traditional territory of the Mi'kmaq people, and also acknowledge that the people of African descent have helped shape the history and the culture of Nova Scotia for more than 400 years. Now, when our government came into office roughly a year and a half ago, one of the first things that we undertook was having our Premier and Minister of Health and Wellness, Michelle Thompson, hit the road and talk, in that case, very focused, talking to people on the front lines, and began a conversation with them, and a conversation that even as we work at these incremental changes that are necessary to make progress vis-a-vis the genuine crisis in our healthcare system to address it, that has been a really fortuitous thing. We have had nurses, doctors, technicians, paramedics, and others say, no one asked my opinion before, and they have opinions. And more so as Nova Scotians, I really believe when folks identify a problem, we tend to have some ideas on the solution. And we are a government that are interested in solutions, so we are interested in your concerns and your thoughts and your ideas here tonight. The only other thing I'm just going to mention is at the start of the weekend, there was a post on social media. Now, social media can be a great thing on your birthday, and catching up with people that you went to school with that you haven't seen in a long time. It's got some downsides too. So there was a post, and the individual who made it, I believe he was well-intended, and he heard a thing. And that particular thing was that the X-ray equipment at Fisherman's Hospital was ready to quit, and the sky is falling. And of course, what does a post like that cause? It causes concern and anxiety. And I'm not always on Facebook. If I were, I would suggest I wouldn't be doing a very good job representing any of you. But I did see it, and I said I will check in immediately on Monday and find out, is this even true? And it's not. That equipment, the suggestion was it was end of life, that there were no parts even available. Again, I would stress, I believe this individual was well-intended in posting this, but it was erroneous, and I was glad to correct that, because here's the thing. We have legitimate problems, legitimate challenges in healthcare, but every day, thousands of Nova Scotians receive the very best care, and that is thanked largely to the incredible people that work in healthcare and some long-standing institutions, including in this area Fisherman's Memorial Hospital and Social Regional Hospital. So as I said, what we're here tonight is to give you an opportunity to talk to us, and we will have our listening ears on. I would like to introduce Jeannine Lagassé, who is the Deputy Minister of Health and Wellness, and as well Karen Oldfield, who is the CEO of Nova Scotia Health. These are two incredibly passionate, hardworking members of an extended team, which includes my colleague Michelle Thompson, who unfortunately is not able to be with us tonight, but all of this information will be going back to our health leadership team to make healthcare better each and every day in Nova Scotia. So with that, I will hand back the mic and be listening closely to all of you.
We can't hear through the mics when the masks are on, so just wanted to let people know that, so that's why they're off. Okay, thank you. Now I will pass it over to our speakers.
I think I'm going to start tonight, is that right? Okay. So thank you very much for that introduction. It's going to be hard for me to call you Susan, because you know I always call you Minister. But we're really pleased to be here tonight, and it's so nice to see so many people in this beautiful facility. I've never been in here before, so it's a real honor and privilege to be here with you tonight. This is our, I think, 9th evening or afternoon that we've been out in community so far. We're about a third of the way through, making our way across the province. And we're here really to hear from you, to hear your questions, for us to provide you with some information. And every time we've been out, we've learned something, and we've taken it back to our discussions at the health leadership team. So we really would like it to be a conversation back and forth, a kind of question and answer, and us, as I said, being able to hopefully give you some information that you're here to learn about tonight. But really what I would like to emphasize on behalf of Minister Thompson is that we know that at this time that the changes that we need in healthcare are big, that tinkering around the edges will not get us to where we need to transform to. And the commitment is really to transform to a world-class health system, that we are not looking to just get a bit better, we are looking to get a lot better. And so that's what we're working to do for the citizens of Nova Scotia. So there's a lot of actually employees of both the Department of Health and Wellness and the Nova Scotia Health Authority here tonight. You would have met some of them if you had gone through the other room. They've been with us on the road in all of these, in all of the communities, and have been doing an excellent job. You may hear from some of them tonight as well, that if there's a question that Karen or I think you could benefit from a bit more detail from their expertise, we will pass the mic over to them to give you some information. But really, please, we want you to be open, ask your questions, and we will do our best to get you the information. As Nancy said, we will respond to any questions that are not able to be answered here tonight. I just went through a bunch today, actually, with our folks back at the office who've been sending out answers to questions. So thank you for being here. We really look forward to our chat with you.
Great, thanks, Jeannine. Maybe before I jump in, you might just touch on two things, the Action for Health plan, and also how we've been working as a health leadership team, and then I'll fill in.
You want me to go take those?
Yeah.
Sure. Thanks. So as Minister Corcoran-Greek said, back in September 2021, we did tour the province. The Premier, Minister Thompson, Karen, myself, and our other health leadership team members, Dr. Kevin Orrell and Janet Davidson, who's the administrator of the Nova Scotia Health Authority. And we took all of the information that we gathered through those sessions and some other consultations that we did after the tour, and we created our strategic plan, which is called Action for Health. And Action for Health contains 6 solutions that we believe will get us on that path to being a world-class health system. So it involves things like health workforce, community wellness, how we deliver services in new and innovative ways. And so that's really the basis of everything that we do, is following Action for Health. We do have a website. I think that probably on your cards or information you would have gotten at the front desk, you could see the Action for Health website address. And on that website, you will also see a whole bunch of information on a daily dashboard that we have there. And it provides you information about what's going on in the health system. It tells you things like how many surgeries were completed in the weeks and days before, how many visits there were to emergency departments. And it's not intended for you to make decisions about your healthcare, because we want you to access as you need to all the time. We don't want you to say, oh, well, the emergency department looks really busy, maybe I shouldn't go there. If you need to go, please go. But what it is intended to do is for you to see where we're at and how hopefully over time the actions we are taking under the plan will improve things. And what was the second thing?
The leadership team.
Okay. And then the health leadership team, the Premier appointed us the same day that Minister Thompson became the Minister of Health and Wellness. And it's myself as the Deputy of the Department, Karen is the interim CEO at Nova Scotia Health, Dr. Kevin Orrell, and Janet Davidson, the Administrator of the Nova Scotia Health Authority. And we meet at least once a week for approximately a half day a week, and we make decisions on behalf of the system. And so one of the things that is different about how we're operating now is that previously, everybody made their decisions often in their silos, not always talking to one another. And what we're doing now is making decisions together. So sometimes we bring our own background and our own organization to the table, but we always make the decisions in the best interest of the overall system. So it's been very productive. We try to move as quickly as we can to keep things moving. And it's been very, very effective from my perspective.
Great, thanks, Jeannine. So good evening, everyone. I might just get a show of hands of how many healthcare workers we have in the room. If you could just sort of give a wave. Great, so we have quite a few. So I like to start our sessions by thanking our healthcare workers for everything that you do and have done, especially over the last almost 3 years, but before that too. It's interesting to me to remember at the beginning of the pandemic when the general public heralded our healthcare workers as heroes. Tim Hortons, everybody, you know, banners flying over bridges and so forth. And now, almost 3 years later, our healthcare workers are experiencing a very different situation when they go to work. And it's can be very dehumanizing. And so I just recognize that frustration, and that's one of the things that we all have to be very careful. In the words of Bonnie Henry from British Columbia, we have to be patient and we need to be kind. They're working very hard for us. So, thank you. And speaking of healthcare workers, it just kind of gets me onto one of the biggest issues that we face in Nova Scotia, and particularly in the Western Zone. I don't know why it is, it just is. And that is the fact that, you know, we're really suffering from staffing shortages and having to work super hard to retain and recruit in the Western Zone. And it's not just here in the Lunenburg, Bridgewater area, but it is really the whole Western Zone. And when you get as far as Yarmouth, it's very difficult. Digby, it's very difficult. And so forth. And so I'm going to be really interested in any ideas that people have in terms of things that we should be thinking about that we haven't thought about. I was very pleased to meet folks from the foundation and to learn that the foundation at South Shore, I'm sorry, I just don't recall the specific name, but has actually hired one of the only foundations in the province that has hired a person to help recruit. So I think that's very progressive. I congratulate you, and I'm looking forward to finding ways to work with you on that. So I would say healthcare workers, this is nurses, it's physicians, it's all across the gamut, would be our #1 challenge in the province. A second challenge is once you get outside of the city, it is, you know, we're grappling with how to maintain a consistent and predictable level of care, particularly in emergency rooms around the province. And this would be a perfect example here in Lunenburg and other areas in the Western Zone. So we are grappling with that. We as well have a pretty, it's a big hill to climb when it comes to technology. And you'll hear from some of the healthcare workers. I mean, we still work a lot with paper and pencils and fax machines, and it makes it very difficult for people to take charge of their own health, because if you see 3 different physicians or specialists or healthcare providers, you have to do the whole intake, your whole drug list again, and every single thing about your health has to be done time and time again. And so we are moving to a one patient, one record environment in our province, where our healthcare records eventually will be right there on the phone, but it will be something that will be able to be accessed by whomever the provider is, and by you personally. So that, I think, will make a very big difference, a lot more efficiency, and should help people a great deal. So those are 3 things I would start with. I guess the fourth thing that's always on my mind is just the work-life balance of our providers, and how we can, you probably heard, as I did on Friday, I think, the story about the travel nurses. And that was on CBC, and talking about how travel nurses make a lot more money than RNs who currently work for Nova Scotia Health. And it's a real challenge to compete against that. And so, you know, I do worry about the work-life balance for our healthcare workers. I worry about how we're going to retain them, recruit them, and make sure that when they go to work, they like what they do. So I'm going to stop there. There's lots to talk about tonight. I look forward to people's questions, concerns. I'm all ears for solutions. And so I turn it back to you, Nancy. Thank you.
Okay, thank you. So I will also point out that we have mic run. I'm sitting down just pointing at people now. That's so polite. But we have people with microphones, so you will not have to get up and go to a microphone. So if you have a question, or if you have a question that you want to bring up, or a solution, and as something that you would suggest as a consideration for the system, you can put your hand up and our mic runners will go to you, so you don't have to get up. I think what I'm going to do actually is start with one of the questions. It's a submitted question, but it's from somebody that's here. So beforehand, people that were attending could send them in, and it kind of speaks to, I think, some of the remarks that you've had already. So the question is, what is being done to increase access to primary care services for those without a family doctor on the South Shore, such as immunization and well baby visits? What is being done to retain current staff in rural areas, given increase in the cost of living and stagnant wages and expired collective agreements?
I'll start. So let me start with the latter part of the question first. So there are a number of collective agreements in the province, particularly in the health sector, which have expired and have been expired for a while. We're getting ready to go to the table on a number of them, and that would include nurses. So, you know, it's we hear regularly nurses in Prince Edward Island have a settlement, or they have a retention bonus, or Newfoundland or New Brunswick, and so forth. And right now, I think it's fair to say that our RNs in Nova Scotia are a little bit lagging behind the pack. Mostly that's because we're going to be going to the table. And I just speak for myself, but from where I sit, my perspective is that, you know, Nova Scotia is the largest of the Atlantic provinces, and we should be leading the pack. We also have the largest teaching hospital in our region, and that requires a certain level of technical skill and expertise that, again, speaks to we should be leading the pack. So we'll have to see how that shakes out, but I would have every expectation that our nurses will be very, very fairly treated. Now, that's not today, and that's the problem. So we actually talked last week at our health leadership table about ways that we can sort of leapfrog that whole collective bargaining process to find ways to help our healthcare workers, not just RNs, but others as well, to want to remain in the province and remain in the profession. And that's not easy. So, for example, one thing that we heard from healthcare workers when we traveled around the province was daycare. Is there a way that we could have daycare services on site or close by that could help our healthcare workers? So we're looking at that. Actually, when we were in Sheet Harbour last week, it was the MLA in Sheet Harbour. You'll laugh at this, Susan, but Kent decided, yeah, we were having a daycare, and he basically announced it at the end of the session. So anyway, I think that something like that, it sounds like a small thing, but when you work shift work and sometimes overtime, it could be very, very helpful. So that kind of innovative thinking, but we also need to find ways to get our workers their breaks, their supper breaks, their break, and that's been extremely difficult to do over the past 3 years. So, the work-life balance, we're talking about folks that go home for supper, they may feed their kids or take their dog for a walk and then go back to work. And that is a vicious cycle that we're just not going to be able to sustain. It's not good for people, it's not good for patients, and it's definitely not good for our workers. So we're open to all ideas there, and we're racking our own brains too, and we go across the country to see if there are any good ideas. On the first part of the question, access to primary care. So here's a stat, and actually I know Dr. Pugh is here, Cheryl Pugh is here, and I don't know if there are any other physicians in the room. I know Cheryl's here, so she can correct me if I go off the rails, but right now what we're seeing is a retiring family physician. Typically it will take 3 new doctors to replace a retiring physician. And the main reason for that is because our retiring doctors have a very large panel size. They could have anywhere from 2,500 to 3,000, even more patients. Our new physicians typically they come into the practice in a different payment model, which is typically an APP payment model, which means they're on a salary. And their panel size is between 1,100 and 1,300 people, so it's quite a few less. So on average, it takes about 3 docs to replace a retiring doc. So if we have 20 doctors retiring, we need to recruit 60 doctors. We're doing well on the recruitment, not well enough. So this July, for example, July 23, we will graduate the largest family practice class from Dalhousie University in the history of graduating med classes. The largest class. It's still not going to be enough. Like, we just can't. So we are very focused on recruitment. The team is nonstop. We're doing well. We're on pace. Last year was a record year for recruiting. I think it was 163, of which there were 75-ish family practice practitioners. And this year we're on pace to exceed that. So it's good, but not enough. So we're looking at, so I'll just throw a few things out. There's no easy solution. And in some ways, I think the days are gone where every person is going to have a family doctor forever. We now look at ways that we have collaborative practices where there could be a nurse practitioner, where there could be a physiotherapist, occupational therapist, other kinds of providers, so that individuals will have a health home as opposed to one doctor for every Nova Scotian. We're looking at ways to have more nurse practitioners engaged. So last year we went from 25 nurse practitioner seats at Dalhousie to 40. We now have, I think it's 178 nurse practitioners in the province. So we're working hard to recruit to that profession. And I'll just as an aside tell you that they've been put to good use the past few weekends in the mobile buses. So you may have seen reference to that in the media. This weekend there was a mobile unit in Weymouth and a mobile unit at Cobequid. And Cobequid, for the 2 days, they saw 77 people the first day and over 100 the second day. So roughly 175 people, of which I'm going to say a third were children. And so that's 175 people that, I'm not going to say every single person was diverted from an emergency room, but many of them would have been. And so, frankly, that's an emergency weekend, having those 2 buses. In Weymouth, they saw 77 people between the 2 days. So the mobile buses we brought onto the scene after the Hurricane Fiona went to Cape Breton to help, but we know from the reception that they're not going to be going away anytime soon. And why I raise them is because the one at Cobequid on the weekend, there were 4 nurse practitioners yesterday working in the mobile bus, and 1 paramedic, and 1 prescribing RN. So this is another program that we now have where RNs who want to further their own education are able to learn how to prescribe. And so we have a number of those in the province. So that's a smattering of the kinds of things that we're doing, and you may want to just talk about other ways that we're trying to extend primary care to, Jeannine.
Yeah, just quickly, I think the other thing is for anyone who's on the Need a Family Practice registry, that as of the summer, access to virtual care in Nova Scotia has been extended to everyone who is on the Need a Family Practice registry. So that's another point of access for people into the system. We've also been making some changes in our emergency health system part of the system, and we're having when people now call for an ambulance or call into thinking that they need to potentially to go by ambulance to an emergency department, we've got some different options there as well. That we're starting with units, a single paramedic in a unit that can go out to see someone and hopefully be able to treat on the spot and not actually have to take them into the ED. So what's done is there's a triage done. They go through in the communications center when the call comes in. There's now a physician in the communications center 24/7, and is it the 29th, Jeff, the nurse starts? I think, is that right, folks? Yeah, that on the 29th, there'll also be a nurse in the communications center. So they're in constant contact with the paramedics out in the field, and they determine, they might say, Karen definitely needs to have a visit from someone, but it appears to be she's not as urgent as some, so we'll just stay in contact with her by phone, and then the single paramedic can go out and visit her, when they're able to, but they're in constant contact with the communications center while they're waiting for that. So we're trying a number of different things that are new, are different, are innovative from our perspective, and just different ways for people to get the care that they need at the time that they need it, but that's most appropriate for them, so that people aren't having to go to emergency departments, and that's really not where they need to be, that really they need primary care either in their home or somewhere closer to home.
One of the things, this is on my mind, and I don't know if folks will have this question, but Lunenburg and surrounding area is kind of ground zero for ticks. Okay. Yes? Yeah. So I kind of don't understand why we don't come to grips with that and actually say, okay, if somebody has received a tick bite or think they have received a tick bite, why don't we divert them to a certain place so that they don't have to sit for 9 hours at the emergency waiting for treatment. So I'm seeing some nods, okay? Yeah. This is actually kind of close to home, too. Anyway, we are looking at doing a solution for that, and likely it's kind of in the works for this summer, but where we don't have people sitting at Fisherman's or any of the other hospitals. We have one place where people can just go and they'll be able to receive doxy or whatever is going to be required. So that, to me, I think will really help in this part of the province. But it actually goes beyond that, too, because we received last week in Halifax, there were 2 people who talked a lot about other tick-borne diseases, and not just Lyme. So in other words, not just Lyme, but other tick-borne diseases that, if left untreated, become, chronic. So this is a big thing. And I don't understand why we haven't wrestled it to the ground yet. I don't know. But it's something that I've got on my little list of things to try to wrestle to the ground and see if we can't come up with a solution that actually helps, that diverts from the ER and actually helps to get people the treatment that they need in a time that they need it. So stay tuned on that one, and if people have good ideas, I'm all ears on that. But that's on my mind.
Okay, and I think we have a hand up over here already about, I don't know if it's about the, so I think we're going to jump right into our question and answer portion of the evening. Thank you.
Well, just because you're on the topic, and this is why we're here tonight, is because anybody with post-treatment Lyme or chronic Lyme, probably a big factor that it's not taken seriously is because Dr. Strang, I think, has been quoted as saying it's a cult. We go to our prescribed family doctor who says, it's my husband, all the problems that are arising are not from the tick bite, it's not Lyme disease because you have had 3 weeks of doxy, which is totally inadequate to nip any chronic Lyme in the butt. We spend thousands of dollars getting tested on our own, trying to grovel in the dark to find any kind of information on how to help. Quebec is now, because of chronic COVID, now chronic Lyme maybe there is something to it. It is a real thing. There's a lot of people in this community suffering year after year after year. Minister Susan, if you have anything to discuss or say, what are you going to do to help many, many, many people in this community suffering? What are you going to do about it? So that's our issue.
I appreciate that, and I guess kind of that's, yeah, I agree. I'm clapping too. It is a big issue, and I think we're just starting to scratch the surface. I know Natalie, I guess, can talk to it a little bit, if you would. This is Natalie Borden, and yeah, go ahead, Natalie.
I can't speak so much to the treatment part of it, but we do allow pharmacists to do what we call chemoprophylaxis. Sorry, take my pharmacy hat off. Antibiotics for prevention of Lyme disease when there is a suspected bite. So I think that's an important factor as well, that, waiting in an emergency room or waiting to go see your family doctor. Yeah, I just wanted to put that out there because I think there was sort of a misconception that it was just through the physician, but that can also be done through the pharmacy. So in those, sorry?
No, I was refused.
Okay. So let's talk about that after, because every pharmacy has the skill to do it and is paid to do it under the program. So let's just figure out maybe what that individual issue was, but that is an option that you have. It certainly doesn't address your point on treatment, but in those situations where people think they have the tick bite and want to get the doxy as prophylaxis, then that is a service that your pharmacy can provide.
So just so folks know, this is Natalie Borden is the person who just spoke, and she's she oversees our pharmaceutical and extended health benefits group in the Department of Health and Wellness. So please do speak with her after so that she can find out what happened there. Okay.
Just to go back to the other question though on chronic, there is some treatment in Quebec and also in Manitoba, of which we've been made aware. So we're doing the research now to see if there's anything there. What can we learn? What can we do? So I totally take your point, and if you'd like to give me your name after, then I can certainly share what we learn, and then more importantly, what we're going to do about it. So thank you.
Thank you. So I guess just from a process perspective too, if you have questions, just put your hand up. And what we've tried to do, and this is the best layout of any place we've been, because I usually have to kind of stand up and point at people. So I feel like we have a pretty good view of where everyone is right now. So if you have a question, And you want to just put your hand up, I'll try to catch your eye as you're putting your hand up, and we'll kind of count off. So I see up here, and I want to make sure that, and again, I do my whole pointing thing, I'm like doing my, yeah, so over here we have someone, and then if there's someone else that has a question, we'll try to make sure that we're getting answers in the order with which you're putting your hand up. And again, if there's follow-up questions, we'll try to get back to people just to try to make sure we have opportunity.
I guess it's not a question. I'll go with the new and innovative, but I wouldn't want to categorize it as new or innovative. It's the personal delegate, and here in a province where so many of us are seniors or super seniors, there's a lot of promotion from a lot of community groups to make sure you get your stuff in order and have a personal delegate for cares. But I, as a personal delegate for 2 seniors, I have, right down to the MSI card, there is no line for anyone to fill in that you are actually speaking on behalf of somebody else. So whether that person has a disability and needs a personal delegate, whether that person has no computer skills or even a computer, or the person, of course, is in assisted living and you're looking after them from maybe, 100 kilometers away as a personal delegate. So I highly recommend, if it's even a physiotherapy requisition, not a spot to say that you're not really who you're speaking for. For pharmacare, I think pharmacare might have been the one spot that I did see it, but it's quite, and virtual care on the online stuff, it's very difficult. You're only allowed, they're not a dependent, you're not allowed to put down that you're speaking on behalf of somebody else, but there's no place to say that you're a personal delegate. And the difficulty of doing that when they're one place and you're another place and you're supposed to be where they are for that one-day service. All right, so that's my thought. I hope you can work on that.
Yes, thank you. Excellent point. We will take that one back for sure.
And it's good when they're making notes when you're talking. That's a good sign. Okay, we have another question here. Where's there? Oh, sorry.
Can you hear me?
Yes.
A lot of people don't hear well. A lot of people don't have phones, and they don't have computers. And if they do have them or access to them, they don't know how to use them. You're starting at the wrong end. I'm only going to say a little tonight. You're beginning to do things where we need them, but you're forgetting the larger group that doesn't have access. That's all I'm saying. I want to talk with you. It's very important. I'm leaving. I'm sorry.
Good night, Shirley.
I want to know one thing. The minister's not here.
No, she was unable to be here tonight. She's out of town right now.
Didn't she know she was going out of town? Who knows where the minister is? Nobody knows. I came to see the minister, and I'm 82, and I've had a rough time, and I know everybody else has, and we're going to get it straightened out finally. Thank you, Karen. I like your business card. Do you have one on you?
They haven't even given me one yet, Shirley, but I tell you what, Shirley, I'll get your name, and I really appreciate you coming.
I'm glad to meet you.
Okay, girlfriend. See ya. Okay, thank you.
Thank you.
I just wanted to touch on virtual care. Shirley makes a great point, okay, a very good point, which is that we certainly know that there are many, many people, not just seniors, who don't have access to a computer, and there are lots of places in the province of Nova Scotia where the internet is less than desirable, okay? Understood. Now, I would just share what two foundations have done. I'm not sure if this is something that would work in this community or not, but the Aberdeen Hospital Foundation for one, and in Bear River for two, they partnered with their local library to have an area where they have a computer and somebody to help people who don't have access to a computer and or don't know how to get through all the rigmarole of a virtual care or other services too. And so that's what they did in New Glasgow and also in Bear River to help get past the fact that not everybody is computer literate, not everybody has a computer, and not everybody has internet access. So just a thought, and we're trying to do those kinds of partnerships in as many places in the province as communities want them.
Thank you. Oh, okay. We'll get one and then two. It's good? Okay.
She picked me. Hi. I submitted a question that relates to caregiving. I'm not a caregiver now. I have been, and I have worked with caregivers. And one question I have is, why are there only now 3 respite beds in nursing homes in between Yarmouth, the Valley, and Lunenburg, Queens? That's what I'm told, that there are now only 3, Berwick, Yarmouth, and Chester. Is that true?
That I don't know personally. I can find out, but I'm hoping that Tanya Nixon might be able to share some information. And Tanya is the Vice President of Operations for the Western Zone. Sorry. Oh, and a continuing care rep. Okay, sorry. Great, thank you.
I have.
Yep.
Hi there. So I'm Bob Jenkins, Director of Continuing Care for the Zone, and that is correct. There are 3. Usually we would have, I believe, 8 across the zone. And when the pandemic hit and we needed access to long-term care beds, as we still do, to move people out of hospital, we, working with Department of Seniors and Long-Term Care, Department of Health and Wellness at the time, transitioned some of those beds into permanent beds. And there's no one here from Seniors and Long-Term Care, but I believe there is a plan in place to try to start bringing some of those back over the next few months.
Okay, so I just wanted to say that the impact on family caregivers who are at home and particularly waiting to get into long-term care is brutal. And I know that you know that, but unless you watch it or you see it in your own home, up close and personal, it's devastating. People who are in severe need are not getting into nursing home beds, and the supports are really not there. And I do know, because I started the services in this region for the Alzheimer's Society, and most of the services are front-ended around early early stage. There are not the supports there, as far as I'm concerned, having worked also for Caregivers Nova Scotia. The supports really are not there for people in mid and later stages. And one thing that's been suggested to me by a caregiver is, the VON has a day program here, but again, it's for people that are at an earlier stage, and there's a lot of need in mid and later stages. So there just really are not the supports, and it's limited in terms of the amount of time you can get respite or home care. Most caregivers can't be here tonight because there is no home care at night, as you know, you can't get it. Yeah. So it's a tough time to hold these sessions for people who would like to speak on this issue.
Thank you very much for raising that, and thank you, Bob, for providing that information. I will take that back to our colleagues at Seniors and Long-Term Care, and we will ensure that there's a fulsome answer provided to the question that you submitted and that we get you any additional information from what you raised here tonight.
I know people that are like so on the edge, they're almost suicidal. And I'm serious. This is no laughing matter.
No, it's not a laughing matter. And what in fact has happened is that, families who are on the edge have actually taken their loved ones to the emergency, left them, and driven away.
Exactly.
And that's not good either for anybody. So we are aware of that. You touch on many issues, but one of them is the need for long-term care beds in the province. We need beds around the province in many different ways. Like, we need more acute care beds, we need more long-term care beds, we need transition care beds, we need nursing care beds. So it's not just one aspect, and this is actually, believe it or not, this touches on one of the biggest problems that we have in our healthcare system, because we have people in hospital who don't really need to be in the hospital. They need to be in a long-term care arrangement. And so we can't get people in because we can't get people out. So that's a huge part of the challenge that we're dealing with every day. So you raise a very important point that touches on many other aspects.
Yeah, so suggestion would be better supports while they're waiting. I get what you're saying about not enough beds, but there aren't any supports to speak up while you're waiting.
Oh, it's really tough, very, very tough.
Thank you. Yeah, and there's...
Hi, my name is Joel. Hi, Joel. Joel, yeah, hi. I have type 1 diabetes, so I'm a regular consumer of the health system. We just moved here in August from Montreal. So I've seen quite a few changes through the period of COVID in the province of Quebec, and I'll speak to a few of the things that you mentioned before. And I've also seen, we're inboarding in Nova Scotia and seeing a significant difference in the efficiency/inefficiency of how we're perceiving the systems that your people are stuck with. The reason I'm saying that circles back to what you were saying about retention and so on, giving them the breaks. I used to work for the government of Canada for quite a while. I know bureaucracy, it sucks. So your ability to get things done, I don't know how you're going to do it. But you need to give your people the tools to work smart. That means aggressively getting them smart tools, abilities, and so on and so forth, so that they are not stuck with paper. All the stuff you said is bang on. I was treated at a research institute in Montreal. They recently offered to the rest of the province outreach from Montreal via telecare to diabetics that are not taken care of because there's nobody out there to take care of them. So from the IRCM, the Institut de Recherche Clinique de Montréal, they have volunteered to the Quebec province to reach out via telecare, by phone, by whatever, to do their thing. I've noticed personally the benefit of an electronic individual health record. The fact that everybody has their own piece of paper, the 1950s way, is nonsense. I've noticed how much more efficient, how much more effective it is to have a single health record. Your way to get appointments for vaccinations sucks, honestly. Look at Clic Santé in Montreal. I'm being poked by my wife here. But
It's okay.
it's okay.
Bring it.
If you look at Clic Santé in Montreal, in Quebec, one-stop shop. There's no, it's very painful. There's a lot of runaround to get flu vaccinations, to get COVID vaccinations. We've had 4 vaccinations in the province of Quebec. We tried to get the latest booster. Well, we can't. Why is that? Because the province of Nova Scotia didn't know about our 4 others. Okay, fine. We did that in Quebec. Click, 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 boom. Oh yes, fine, done. In Nova Scotia, it's going to take 3 weeks for some poor human to go clickety-click to take the stuff that I input in a computer to type it back in. I don't know. So why does it take 3 weeks? That's wasted effort. That is not rewarding work for a health worker and so on and so forth. So I think you need to be aggressive in, and also human factors. You know, the lady who left, we need to make it easy for people who aren't geeks. Don't write front ends to applications that look good to a programmer. You know, give it to people and test drive and say, well, this needs to be polished. This needs to work smarter. I don't understand what this means. So make it easier, because then the easier it is, the less wasted effort. So those kinds of things. So variety of comments.
No, I mean, you're talking to, we would agree with you 100%. We would be having a violent agreement. And the only issue is, how do we get there faster? Like, so our issue on that would be speed and how to accelerate. And that's kind of what we're talking about now, and how to digitize more quickly. So yes, agreed, 100%. Do you have anything you want to say on the COVID vaccinations? No? Okay.
Why does it take 3 weeks?
That I don't know that. I don't know the answer to that.
That's the first time I've heard that long, but I've written that one down, but
The first reaction I got after I typed in all 8 of our vaccinations, it said, we'll get back to you in 3 weeks. Don't call us.
okay, I don't know.
Yep.
I don't
Don't
know. I will
know.
look into that one for sure.
In relation to that, I had the same thing. I'm going away in 2 weeks on a plane, and I said, this is ridiculous. And she said, let me talk to my superior, and she did it for me. So I phoned up, and that's how I got it. But sometimes you just got to push.
Oh, most times you have to push, but that's it. But you shouldn't have to. Okay, that's the point. You shouldn't have to. It should work. So, yeah, we don't know, but we'll find out. It's a dumb rule. Agreed. Nancy, help us.
We have a question over here.
Hi there. Thanks for taking my question. Going back to the lady with the home supports, I just want to broaden that topic a little bit more, just to encompass all community supports, VON, palliative care, home supports. All of those help to keep people out of the hospitals. We need to put more resources and finances into those community supports, because they are doing, not only do they help people stay out of the hospitals, but they help the general population to stay sane.
Yeah, here.
Just to add one more thing. Have you done any research to look at other models of care for community support, such as the Danish model of care, for example?
Go for it.
2 things. In Solution 6 for Action for Health, it is all about wellness. That's the wellness piece. So I know that's not just what you were talking about, but generally community support, how we engage with community-based organizations, community wellness framework. So that's the work that we're going to be completing. So that's where you would find that in Action for Health. If you're interested to kind of see what we're going to do in that area, that's where it is. It's interesting that you raised Denmark. At the end of June, just this past year, Minister Thompson was invited to participate in an international conference in Copenhagen, and she presented there on some of our COVID experience. And very luckily, Karen and I were able to go along with her. So we spent a week doing exactly that, studying the Danish system. That there was the conference we attended, but we also spent 3 days doing everything from attending a general practitioner's office to going to their emergency health ambulance system, main communications center. We spent time with life science and clinical trials people, so we actually do have quite a bit of knowledge about the Danish system, and we've kept an ongoing relationship with them. They actually were just here visiting within the last month, and so it's an ongoing relationship that we're continuing to learn from.
They have a great care at home model, like a top drawer. One of the other things that we learned and we're very interested in, one of their hospitals has developed a chemo to go initiative. So basically, not for all cancers, but for some cancers where the patient can basically go about their daily routine and receive their chemo while doing so. So we've struck an MOU with that hospital because if we can do that, we want to do that. Like that, to me, if you can preserve your quality of life, notwithstanding illness, then that would be a very good step forward, especially for people who are, outside of Halifax proper. It could be really helpful. So we're things where we can develop those partnerships, learn, we're doing it. Now, in return, the Danes want to learn about our robotics, because our robotics is depending on which robot you're talking about, we're number 1 or number 2 in Canada. And we don't always talk about the things that we do really well, but that is one of the things that we do very well, and they want to learn.
Okay, I was just doing my, yeah.
Two months ago, I had an accident here in Lunenburg. I live in Bridgewater. I fell off the dock, the floating dock, into 15 feet of water. Impact injury, I fractured my heel. I lay on the dock for over an hour. The ambulance was called, and then we were told that it could be another 3 hours. Luckily, I had a friend who took me into the hospital in Bridgewater, and I sat in Emerge all night, soaking wet clothes. Finally, at about 5 o'clock in the morning, I got a cast on my foot. Next night, I had to go back because I was having so much pain. Another friend sat with me all night to have it loosened up and whatever. So I live alone. I had to crawl into my house on my hands and knees. I've spent the last 2 months luckily I have a good network of friends, and so they've done everything that I could not do. Could not, having trouble getting dressed, I couldn't get groceries, I couldn't drive. I finally got my cast off this week. So, but if I hadn't had this network of friends, I'd be destitute. Oh, okay. The accident wasn't reported. There's it's on and on and on. But I did get excellent care from the doctors in Bridgewater, and I got excellent care in Kentville. But anyway, that's the system. And the thing is, it was also 8 o'clock at night, so I fell between the floating dock and the pier into 15 feet of water in the dark. There was no light, nothing protecting me, and nobody at the museum has even contacted me to see how I am. I'm not real happy with what happened, but I've been doing the best I can to make the best of a bad situation. But there's some changes that need to be done with the system. Anyway, thank you.
Thank you.
Thank you.
I'm sorry that happened. That happened to you, and that you haven't had the best of experience.
I'm alive, and I'm very grateful because, if it hadn't been for the 2 men that fished me out from my arms, I could have been dead.
Absolutely. I think there were a number of things you raised that I think that we could comment on there about some things, and not that it will in any way, change your experience, but maybe some of the things that we are working on. Jeff Fraser is here from our Emergency Health Services group, and would you be interested in hearing a bit from him about kind of some of the things that we're taking, some of the initiatives that we're implementing in regard to the ambulance system and improvements that we're hoping to be made there. Then Jeff could comment on those.
Thank you. I echo Jeannine's comments. I'm sorry that has happened to you, for sure. At the start of the session tonight, really we talked a bit about access in primary health care. And so Jeannine walked us through some of the changes at a very high level that are happening in emergency health services to help create some of the capacity that we need to be able to make sure we can have much better response times in our communities. I'm not going to rattle off a bunch of numbers, but I'll give you one to think about. About 70% of the people that we see in our EHS program are considered low acuity. So some of these programs that we're putting in place with our doctor and our communication center, adding the nurse into the communication center, and the integrated approach is about providing ways to deal with people and give them enhanced care pathways so we have ambulances available for the 30% that you fell into. So these changes, that's one of many changes. The other piece is that our system has been built in a way that we had the entire system do the transfers and all of the emergency and urgent systems work. About a year ago, the system undertook a redesign and really began to separate out our transfers. And we looked at many, many years worth of data. We're very comfortable that a lot of the calls that even happen between facilities don't really need paramedic care. They just need a way to get there to have their care continued. So about a year ago, about somewhere around 85% of all the patient movements that are happening in between hospitals were done by paramedic units. And our last look, we're about 22%. We're convinced that we can get to about 5%. What does that mean to you? That means, in the big picture, that's going to free up some capacity within our system. We have some other challenges with staffing. And we have challenges with demand, but all these bits and pieces that we're starting to assemble together is about creating capacity so we can be there when you need us and you don't have to wait 3 hours for something like that, so I do apologize.
Oh, thank you. Yep, perfect. I do have lots of submitted questions too, so don't feel any pressure. But if you do have questions, just please.
Now I don't even know what I wanted to ask, but I am one of those healthcare workers, and one of the things that I see is that it's not just about recruiting healthcare workers, you need to retain them. And I'm one of those healthcare workers that was pretty close to being burnt out. I see it within my facility that I'm working at. I see it within the province. And part of that is that we haven't, there's lots of reasons, but one of the reasons is the inequity within our healthcare system within the province. So if you're working side by side next to someone, you use the example of the travel nurse, how do you think the nurse that's working next to the travel nurse feels? How do you think the sole dietitian at a regional hospital feels when that same size of hospital has, 3 or 4 dietitians? How do you think it feels when your facility cafeteria closes at 1:30 and there's nothing to offer people waiting in the emergency like I did with my brother? There's nothing. Absolutely nothing for them. I'm a dietitian, and there's nothing. We have markedly less staff within our kitchen in the hospital. We have to ask the foundation for things that should be covered in our budgets, but no one ever talks about, food budget, or we're just the lowly person. But even within all that, what I really is that whenever you talk about primary health care, you're always just talking doctors and nurse practitioners. Again, another big inequity within the province is our primary health system. And I've worked in many different places around the province. And in this area, we don't have some of the services that they have in other areas within chronic disease management and within primary health. So I dream about primary health being some of what you're talking about, is that we should be able to access a full team of people, that a clinic is not just a doctor, a clinic is not just a nurse practitioner, a clinic is a full team, and that you shouldn't have to go through your doctor to make an appointment to go to the diabetic clinic. If you're a diabetic and you lost touch and you just want to get back into it, you should be able to, today I know I want to get back on track, I want to just call that diabetic clinic and have a team. I want to see a dietitian because I've got a question, or I want to talk to the nurse, or I need a social worker. We need to have teams of people, and we need to have the same teams of people. You know, if you have a good cardiac rehab program that's in Antigonish, why can't you have a good cardiac rehab program in this area? There's many reasons why there's burnout, but inequity is one of them. And being overworked is another. So you will burn out people really, really fast. But work on it.
I think those are great points, and that's a great message. Could you please pass that on to all your friends too? Because like, I would agree with you. Well, so it's been said of me as well. So, you know, I talked earlier, I used the term health home. It is, and you know, I don't mean to, I certainly, when I talk about the team, it's the gamut, right? It's not just a physician, not just a nurse practitioner, but I don't like to minimize anybody's role. You know, so sometimes I would be guilty of saying doctor or nurse, but in my own mind, that's a team.
I get it when you're talking
Yeah.
so that people understand.
Yeah.
But talk's one thing, bring on the money.
Show me the money. Jerry Maguire, show me the money. Okay. Yep, show you the money. All right. It's, yeah, okay. I'll take that home. No, I hear you. You know, and the inequity is a real challenge, and that's going to be something that we have to grapple with. Not just financial inequity, but as you say, if there's a program here, why not here? Why not here? Especially if it's best in class. When they're best in class, and you know, there was a question, I think, in the submitted questions on the inequity aspect. Maybe it was your question, but where there are good things happening in Nova Scotia, we need to scale them. We need to take them to other parts of the province as well. And yeah, agreed. So now we just have to find ways to do it, find the people and do it. Well, I can tell you that we have spent a fair bit of time. We've spent a fair bit of time retooling and making it easy for retired healthcare workers to get back into the system. Okay, so we had that tested by retired healthcare workers, so I know that one works. So you don't, no, you're not retiring in 6 months. You can retire, take a month off, you can be back.
Thank you. Do you have a question here?
Hi. I have a more global question. First of all, do you consider affordable housing to be a healthcare issue? And if you do, let's get maybe a yes. Okay. If you do, what municipal linkages do you see? Now, I'm from a community that's building like crazy. We've got apartments popping up like mushrooms. And the word is, we all go and look at them, and they start at $2,000 a month plus.
And I'm not poor, but everybody I know is wondering where we're going to go when our spouse passes and we can't afford a house anymore or whatever. So even those apartments, they should have 4 bedrooms if we have to be the Golden Girls or whatever. So you get my question. I've been to council for a senior center that we started, and I addressed both councils, municipal, the town and the municipality. The municipality answered back immediately and brought help. My town literally said, we'll get back to you. So what is the municipality doing on accountability on this issue to link with the province and the federal government?
I can't answer that part of the question, but I can tell you that, yeah, we talk a lot about housing and the other social determinants of health, right? It's a big discussion that we have. Karen and I meet with my deputy minister colleagues often, so the people who would be at housing and municipal affairs, people at community services, people at economic development, and things that they might be able to help out. So I can tell you that Action for Health is a whole, not just a whole of health system plan, it's a whole of government plan, because we will not be successful in achieving better health outcomes unless we have all of our government partners with us, including housing as a very big one. So absolutely, we are talking about it, and I'm linked very closely to those of my deputy colleagues in those particular departments. Yeah.
Last weekend, I think it was Friday, there were 10 unhomed persons in the ER in Halifax. And so it is a very real concern. And, you know, so what happened in that particular case last weekend, you know, the Department of Community Services, you know, was advised and became involved. But it's a stopgap. It's a Band-Aid. It's not, you know, it's not, it's like solved for a day. It's not solved for the long term. So you've put your finger on a really important one. It does impact us because of the reasons that I just say, but it's a whole of government solution that's required. You know, we can just give some input and we can give the statistics, but we can't, you know, wave the wand and solve it ourselves, that's for sure.
Joan Parks mentioned the caregivers issue, and I saw a really strong example of that one day. I was on duty, and a man rushed in the door who was a full-time caregiver for his wife who had advanced dementia. He was out trying to look for affordable housing because he was going to lose his unit when there was no longer 2 pensions, and he didn't have half an hour. He said, where am I going to go? And he was fully burned out already. And that's just one small example of it at the lower end, but it goes higher up.
Okay. Oh, okay. Yeah, back there, and then there's somebody over on this side too. So we'll get you up here, and then we'll go over here. Yeah.
Great. Hi. My name is Christine Amla. Oopsie. Almost missed the step there. Christine Amla. And I don't have a question, but I was hoping the minister would be here this evening. I dropped a letter off to her, I believe it was October 18th or 19th, to her office. I wasn't permitted to go up to her office, so her secretary came down and collected my letter from me. Right up till today, I've not received a response to my letter. Then I emailed her, and I've not had a response to my email either. I've tried to call in several times, but with the recording, it sort of cuts you off, tells you to call back. So I'm just wondering, Deputy, if you could relay to her that Christine Umlaw was here tonight, hoping to speak with her, the minister, and if somebody could get in touch with me, I would really appreciate that.
I can guarantee you before I get home tonight, I will have sent a message to someone in the department looking for that correspondence, so I can see it in the morning.
Thank you.
Absolutely. I apologize for that.
I'm grateful. I appreciate that. Thank you for your time. Thank you.
Thank you. And there's a gentleman. Oh.
Thank you. Hi, my name is Stephen. I live in town. First off, I'd like to just thank everybody for their hard work and dedication. I mean, I'm in the light, eh? It's not good, I know. And I'm Jesus, and you should...
No, it's the light. It's the light.
It's the light. I'd just like to say that for 68 years of my life, I've been taken care of by a fantastic medical system, and thank you for that. Back on the line with my wife, Irma, I think the problem is we're so desperate, we're reaching out to naturopaths with tinctures and herbs and vitamins to buy ourselves time because we still have faith. So I just ask that keep going, keep looking, right?
Oh, we're not giving up. Don't think for a second. Like, one of the reasons I like to do these is so I can hear, and I also hope that people come away knowing that there are people working their butts off to find solutions. Their butts off, and we're two of them, but there are many others here, and they do it because they care and want to find answers. So I also want people to go away with hope too, because as there are real bright spots in our system, and we have wonderful providers. We have like fantastic clinicians. Like, for example, I got two. I do get good emails too. So for example, today I got a great one to start the day. It was from a doctor who last month began to provide care, virtual care in Nova Scotia. And the note was, I wrote, he said, I saw 200 patients last month. These are 200 people who didn't go to the ER, who didn't have to leave their house, who didn't use gas, who didn't have to, didn't have to take time off work, and listed off a number of things. Now, virtual care is not the be-all, end-all, but for certain things, it's really marvelous. And he felt really great about the fact that he was able to provide care to 200 Nova Scotians relatively easily. He felt good about it. He felt good about himself and the fact that he was able to do it. And then I received another email from a colleague who had had hip replacement surgery and who had nothing but great things to say about the care and such and so. And so, we're here to talk about problems and find solutions, but there are many, many, many good things. We've got amazing researchers, like world-class researchers. So for example, Ken Rockwood, who his work in frailty is known the world around. He received a $250,000 award earlier this year from like a very prestigious award. And he's known better outside of Canada than he is in his own province. And there are others like Michael Dunbar, Dr. Dunbar, who's doing amazing things with his robotics and being able to do, hip and knee surgery with robotics. And we're just at the beginning of this. We're just at the beginning. And so, we have a health innovation hub where Nova Scotia Health partners with clinicians who want to find solutions to problems. So for example, we have Dr. Jan Summers in Colchester Regional, who at the beginning of the pandemic said, you know what, I got to do something. She was kind of twiddling her thumbs because at the very beginning of the pandemic, people were not going to the hospital. They were staying home. She's an ER doc. And she just using her own ingenuity, found a way to provide it's called Virtual Care ED. So basically it's a way to expand and extend emergency services through virtual care. And we're doing it right now at Colchester and I don't know where, Tanya, in the Western Zone, you're in Yarmouth, and I think there's one other in the Eastern Zone. So basically how it will work is that there's an area in the hospital. There will be a person on site who is able to relay symptoms and the issues to the ER doc who may not be on site, could be home, could be somewhere else. This isn't for, all emergencies. This is for low acuity, but nonetheless, she developed the technology. She did it all herself, and so these fantastic people exist all across our province. I'm sure they're right here in Lunenburg too. I just don't know who they are. So I don't want people to walk away thinking all is bad, because there's so many good things too, and mostly the good things come up from the people. From the people.
Yeah, and just to pick up on that we are very committed to this, and a number of the staff that are here in the room tonight, who staffed the tables that were there before and are listening now, have come to all of these sessions because they want to learn from the community, right? So I think that there's a very committed group of people, both in the department, in NSH, at the IWK, in emergency health services, who just want to do better for all Nova Scotians. So that's why we're here to hear from you, right? So that we can hopefully do better.
Yeah, and I've said at other group sessions as well, like, there's political support, we've been given financial support, and the only thing that is impeding progress is our collective imaginations and our ability to do things fast enough. That's it. Go ahead.
Yep, we have a question right in front here, and then I think over here, I do see you. I get caught listening sometimes, so
Sorry, thanks. Just to get back to it, and the whole virtual care is wonderful. I think this is the best thing that's come out of COVID, is the fact that now you can just call your doctor or see him on the screen. But the problem is, we have a family doctor who does not believe in what we're dealing with, and we are not able to access any virtual doctor because of that. We're shut out of the system, or we have to pay more for other private things. And it would be so great if we could, even with a family doctor, just to get a second opinion, be part of that virtual system, and maybe be directed to whatever problem that people are dealing with, that would be forwarded to a specialist in that field, that would be, even if it's just answering an email or making a suggestion. I think that would really go a long way.
I can always bring that back to your information that you're giving us for virtual care. We have meetings weekly, and I'll bring back your feedback as well and see if there's anything we can do to help there.
Just to have it more open to all Nova Scotians.
Well, this has come up at previous sessions as well, and so let me just talk a little bit about this. I mean, I don't know if there's folks in the room who have used it or not, but so Jeannine said, if you're on the list, need a family practice, and then you're eligible to go on to virtual care in Nova Scotia. So right now, that's over 100,000 Nova Scotians. However, it does work reasonably well, not always perfectly, but reasonably well, and so well that really most people want it, especially for easy things. And so that's already on the books to start to scale it and expand it. And the only thing that will hold us back there is to make sure that we have enough providers to be able to provide the care. So I look at the numbers every day on our virtual care, so I kind of see where we are, and I just relayed the info from that one physician who was really excited about it. But to get to all Nova Scotians, it's going to take some time, only because we have to get care providers signed up and who are willing to provide the care through virtual care. But that's the plan. The plan will be that it's all across Nova Scotia. And I guess I should also say, there are some bogus virtual cares out there. Okay, like there are some, I say bogus, but virtual care, that's ours. It's very safe, it's very secure. There are others being advertised who aren't necessarily regulated through the Department of Health and Wellness. And so, for example, there is one of which we are aware that somebody, people have gone on, they've received some kind of care, and all of a sudden a fax shows up at a specialist's office, see this person immediately, okay? where this specialist just has there's no connection to our Nova Scotia healthcare system. So providers are coming from, other jurisdictions. They're not being regulated here, and that's a problem. So I would just urge people to be careful. Virtual Care Nova Scotia is 100% our product, very safe and very secure. So just be careful what you're doing.
Thank you. We have a question over here that's...
I just have a question of, I don't know who I'm asking, but I'll say it to you. I want to know if, me as Joe Public, is there a way that I can access my health information? There used to be in this area, and then they told me, no, the contract lapsed, and so it's no longer available, but I didn't know if there was such a thing in the works, or is there something that is provincially available?
Not at the present time, other than you probably would know like your vaccination records and that you've been able to receive that, right? But we are working on it. There is but you're correct. The previous product was called My Health NS, I believe, is that what you're referring to? And you are correct that particular, it was a pilot program at the time, and then it did not continue after. But we do have a couple of digital things in the works, and all related to, as Karen spoke to earlier, kind of our one patient, one record program that we're hoping to be able to continue, and then things would evolve from that. It's actually one of the things that we spent a lot of time learning about in Denmark, right? Because they have a very sophisticated system there where people have just one identifier number that everything is attached to, and they have 50 plus years of data on all of their citizens, and it's accessible on your phone. Right? So those are the types of things that we're looking at.
That's where we're heading.
That's where we're heading.
We're heading to,
but
what you want is on your phone.
Joel's comment over here, right? We're in the paper and fax machine world right now. So we're looking to accelerate as much as we can, and that is absolutely the intention, is that people would be able to access their information right from their phone.
Do I dare ask how quickly?
Well, don't quote me, okay? Don't quote me. If you promise not to quote me, I will tell you probably towards the back end of the first quarter next year, you will have something. Something. It's not going to be the whole enchilada, but it's going to be a start. Like we're on a time schedule here, and we have a very demanding boss, and so that's why we don't sleep a whole lot. So, no, I mean, people want this. We want it. I want it. So, soon. Very soon.
So don't quote, but it's being recorded, but whatever.
Oh my God. Strike that from the record. I forgot about that. Strike that from the record.
But I think Karen makes a good point there as well, just not just on the digital side of things, but on everything, that we're trying to roll things out as well as we have them done, right? Mm-hmm. So we're not trying to get to the very end of the game. Once we've got the first inning done, then we're trying to push things out the door, right? So that's what she said. So on something like that, you might not see it all right at once, but we're going to try to get out to you what we can as soon as we can.
Thank you. And there's a question in the back here.
First of all, much like this gentleman said, thank you to this government for acknowledging that there is a problem in the healthcare system, and thank you for addressing it and allowing public input. Second, to this lady down here that had the accident at the museum, I'm sorry that happened to you. My name's Bruce. I used to be a paramedic in Nova Scotia. I was a paramedic for 27 years, and I left at the end of 2020 because I guess it was fair to say I was almost burnt out. I won't say I was, but I was pretty close. There were a lot of things that were frustrating me. I've been frustrated since 2018. COVID had nothing to do with it. I was frustrated since 2018. I was looking for a way out. I had another profession in my back pocket that I had been doing on a part-time basis, and something came up full-time, and I took it, and I haven't looked back. I have no regrets whatsoever. Having said that, there's been a lot of paramedics that have left since 2020. I was in contact with the union's business manager earlier this week just to try and get some stats. And what he told me was that from January 1st of this year until October 31st, roughly 100 paramedics have left. And in the same time frame last year, about 100 paramedics have left. when we're talking about 1,000 to 1,200 paramedics in the province, to me, 200 is a big number.
Yeah.
So I guess my question is, and I'm sorry this was an online question that I had submitted. My question is, or sorry, right before I get to that, I see on the EHS Facebook page, they're doing a lot to recruit. My question is, what are they doing to retain? What are we doing to keep the paramedics that we have now from leaving? Of those 200, the ones that have left, they've either, like me, left the profession completely and moved on to something else. They've maybe moved to another province to stay in paramedicine, or they've stayed in the province and maybe got lucky and they're working in a hospital doing as a department medic. But we need to keep the paramedics that we have on the ground units, Life Flight, the communications center. We need them to stay here because there's a ton of experience there. And I don't know how many students the schools are able to put out. They might be able to put 200 medics back into the system, but they're not getting the experience that they're losing for the ones that are going out the door. Thank you.
Yeah, and Jeff, jump in if I get this piece wrong, but the same as in all of our health professions, paramedicine is no exception, right? On the number of people who are leaving, kind of the same things that you said to us too about nursing and dietitians and everyone else that works with you in the system. We have started, and this is, correct me if I'm wrong, Jeff, but it's the department, NSH, the paramedic college, the employer, the union, and I think that's, and we've started, and it's exactly that, kind of a workforce related group for discussions in regard to how do we tackle some of these issues in regard to retention. One of the things that Karen and I and the health leadership team have spoken about is, as I said earlier in some of my comments, EHS and the ambulance system used to really be seen on its own and not as integrated into the whole system as we are trying to see it now. So we're also trying to look at options for paramedics, for instance, to do potentially some kind of rotation. So to your point, they're on the trucks, they're on Life Flight. Sometimes maybe they could work, we could have some kind of rotation into NSH as well, and then get people through kind of different positions. So they're doing some different things as well. So we're very attuned to the paramedic issue in particular, and trying to work with all of the partners that would want to have input into it to find ways to retain.
No, you nailed it.
So I have a question here that was submitted tonight from someone here that wanted me to read it, so I am going to read this one. But it's actually was submitted from, there were a fair number that were submitted previously as well, and it has been kind of alluded to as well, but I think it's important to read it around the recruitment of physicians, and I think we could, substitute healthcare providers. And just wondering if you could briefly outline the process of finding prospects for doctors working in practice and the entities who touch the process, and why is it so hard?
Oh, such a loaded question. Where do I begin? Well, I'll just begin with what I learned over the past year. First of all, there's a lot of cooks in this kitchen. A lot of cooks in the kitchen. However, we've streamlined it so that we pretty much know what needs to get done right now. We have an office of healthcare recruitment, and the office right now is co-led by one of the ADMs in the department, which a gentleman by the name of Craig Beaton, and Dr. Nicole Boutlier, who's the VP Medicine at Nova Scotia Health, and the office is charged with the strategy for recruiting. In other words, what kinds of doctors, where we might recruit, different kinds of models that we might use to appeal to somebody that's coming from outside of the province or outside of the country. So for example, right now in Nova Scotia, our two of our highest needs are anesthesiologists and psychiatrists. We really need anesthesiologists in the Western Zone, particularly in Yarmouth, as an example. So we lay out, what do we need? we need to look at retirements or pending retirements, and we set out all our needs, and then where are we going to find these doctors? So we have the office that runs that show. However, we also have the College of Physicians and Surgeons, which is responsible, it's the regulator, also licenses individuals to practice in the province, so they're involved. Typically, you would have Dalhousie Faculty of Medicine producing graduates, doing the residents, and residents have to go through a very complicated matching system. So they apply from all over the country and sometimes beyond to do their residency in Nova Scotia. So that's another piece of it, and the whole CARMS piece of it. That's an association as well. Sometimes the Royal College of Physicians and Surgeons, which is the national body. And who have I missed? So there's a lot of fingers in the pie.
Immigration.
Yes, potentially immigration. If we're talking about an internationally recruited physician or somebody who's been educated outside of Canada. So it can get really complicated, and it's extremely aggravating and frustrating when it should be very simple. It should be, it's not. Because we don't control it all, we have to work with people, and we have to find ways to build a coalition of the willing. One of the things that we're looking at is an Atlantic-wide college, so that there could be a little bit more freedom of movement within Atlantic Canada. But as you can appreciate, every province is guarding its physicians like really tightly. And so I'm not sure how quick we're going to see the walls come down as between the provinces, but it is something that's being looked at. And as well, they're looking at it nationally, so that there would be a governing body for the whole country so that physicians can move more freely. I worry about that a little bit because it may advantage provinces that have more dollars, potentially. So that's not really a great answer, but it's an explanation of why it can be so difficult. So one of the things, what we have to do is really focus, really focus. What we're very good at in Nova Scotia is pulling these partners together and working well with the partners. So we do work well. Once we target and we focus, then we can, make some gains. Just going back to what the foundation has done with the addition of a staff member, the province 2 weeks ago or 3 weeks ago announced a fund that communities could access to help them with their recruiting efforts. So for example, whether it's to market or to host a visiting physician, but there's some, an additional financial package to help people to recruit. So I'll just share that if you didn't already know it. And we do have some really great examples of communities across Nova Scotia who've had very good success in helping to recruit. And I'm thinking in particular, there's a group in New Glasgow who's just excellent and they have best practices. They work really well with their hospital, with their foundation, with their community to do recruiting. So there are places we can look to learn, and I'll give you their names. Like they're just outstanding. Yes, Healthy Pictou County, and so everybody does things a little bit different, and that's another reason why it's important to go around the province, because it's not a cookie cutter. It's not a one size fits all, and I think it's important to recognize that each community is a little bit different, and it's important to play to the strengths. So. I'm surprised that the question hasn't come up tonight about your palliative care unit. Oh, Jeannine needs to add before we get there. Okay, go ahead.
Yeah, I just wanted to add one thing that when Karen mentioned the community fund, because we also know that we can find as many people as we can, but it's really the community that keeps them there. And so that actually you all are recruiters for your community, and you're all the people who we need to help us to retain the people that we find. It's just a really, really important part of the process is the community behind all of these people who come to work in healthcare for you. So the other thing I think before, so we don't miss it, is I'm going to steal your thunder a bit tonight, is if you know any young people in your lives who are thinking about careers, thinking about early stage, really, please, encourage them to look into working in healthcare. Like, it's an incredibly, incredibly rewarding career, and we want to try to get people interested as early as possible. And it all kind of goes together for me. It's all about the community, right? And who you're bringing up through the community, who you're bringing into it, and then how we keep them there to support you.
Yeah, like for example, I can remember 2 years ago, many of the servers in Halifax, like Smitty's, wherever, Cora's and so forth, it doesn't matter, were science graduates. Many of them from St. Mary's University, which is my university, and I know the university well, and I know the quality of the students produced. There's no reason a science graduate in this province cannot find a job somewhere in healthcare. They may need to upgrade, we may need to bridge them, we may need to do some things, but there is no reason. So, yes, kinesiology students, it's another one. Like, we don't hire that many kinesiologists per se at Nova Scotia Health, but with that kind of training, there is no reason we can't find a spot for that graduate to land somewhere in our healthcare system. I mean, we have a lot of vacancies. So, yes. Yes, we do. Yes, we do. So palliative care. So I toured your hospital late summer, I guess, and actually, there's two quick little stories on this one. First of all, it's beautiful. Your unit is beautiful. Every part of it is just amazing. And so if we could only find a palliative care physician, we'd be in business. So we're on the hunt, and in fact, I had a little note from Cheryl earlier today. We have a number of persons who are actively being recruited, and trust me, it is high on the list. I've seen it myself. It's a beautiful space, and I understand very clearly, particularly based on the comments made here tonight, how important that is. And when dollars have been raised and you have the space, it's very important to make sure that it's properly utilized. So I do understand the importance. When I did that visit, we were in the room where there's a beautiful mural, and I'm sorry, but the name of the artist escapes me, a local artist. I think she's in Blue Rocks. Anyway, we wanted a picture taken, and so I walked down the hall to see if there was somebody that could just take a picture. And there was a young man. I said, "Can you take a picture?" And he said, "Sure thing." So we had a name tag, Jojo RN. So I don't know if y'all know Jojo. Okay, you know Jojo? So I said, "Jojo, where are you from?" He said, "Well, I'm originally from India. Where did you go to school?" I went to the University of Kerala. And I said, "When did you come?" 10 years ago. Was it difficult? Simple. But I have 10 friends in Bridgewater who can't get into the system. Okay? Wait for it. So I said, "All right, give me your email." And he did. And so as soon as I got back to the office, I had someone call him. He's now working for us as a navigator to get those 10 people and all their friends who are also across the country. Okay? This is what Nova Scotians do really well. Put two and two together and connect people. So just that little happenstance, can you take a picture? And good things have come of it. So I just, as Jeannine said, like, keep your eyes and ears open. I mean, we're open for business.
I feel like that's our mic drop moment, and I know they're there, done. Thank you for that, and I know there might be some outstanding questions, and if there are, then just let us know, and you can fill out a card with your contact information if we didn't get to you tonight. I say we like I answered any of the questions. These guys will get back to you. And thank you so much. And every time we do these sessions, and I will say that this was a really great session tonight, and it was really good to have the engaged conversation. And again, I say thank you to the leadership team that comes out and answers these questions, because you know it's hard to put yourself. I would anticipate it'd be hard to put yourself in front of people not knowing what these questions might be, and so I think that's really commendable, and to come out and to be engaged in your community and ask the hard questions is also commendable. So thank you for that. As I said, this is being recorded and it will be posted. You'll be able to watch it online. And I just want to say thank you again, and have a good evening and safe travels home. Thank you.